Hello and welcome to the Complete Health Podcast, the podcast that brings you a complete view of healthcare, exercise as medicine, and much more.
We're your hosts, Helen O'Leary and Reece Noble, both physiotherapists at Complete Physio and Pilates in London.
This is episode 17, the second of our COVID special episodes with respiratory physio Emily Lockwood.
Episode 2 with Emily is very much aimed at therapists who are caring for people who are post-COVID. She speaks of the importance of pacing during not just rehab sessions, but also everyday life, and how there are still many unknowns in the care of this population.
Hello and welcome everyone to the Complete Health Podcast. I am your host, Reece Noble. I'm one of the physiotherapists here at Complete Physio. As always, I'm here with my co-host, Helen O'Leary. Welcome back again, Helen.
Hello, nice to see you again.
Nice to see you. And this is part 2 of our two-part series with Emily, what is your surname? Sorry. Lockwood. I was trying to think about it before. That's horrible. I just see you in the corridor and just say, hey, Em, how are you?
It's Emily.
Em Lockwood from Air Physiotherapy, who Air Physiotherapy actually work with us quite closely here at Complete Health in Chelsea. And Em's a wealth of knowledge with all things cardiorespiratory physiotherapy. And episode 2 now with Em is going to focus and be tailored more towards people like Helen and I, who are actually therapists, where episode 1 was more for a bit of a resource for patients. So we're going to go through and try and give out some really good quality information for therapists who are seeing people post-COVID, because if anyone listening out there who's a therapist is like me and starting to see a few of these patients, some guidance would be nice, because I haven't done a lot of cardiorespiratory stuff since uni, which was 11 years ago for me. So hopefully this serves as a really nice resource for people like that. So again, Em, thank you so much for being with us and giving up your time this evening. We do really appreciate it.
Pleasure. Thanks for having me on.
Perfect. Now, as I've just touched on, episode 1 was tailored more towards patients, but I've learned a heap out of it in that 40 minutes. Mm-hmm. So if any therapists, go back and touch on that as well. And there will be a lot of overlap between that one and this one, and we'll expand on that a little bit more as we go along. Beautiful. Helen, go for it.
Awesome. So I think as well, obviously this is great for physios, but more and more we're all talking about health and well-being. And I read something in the Sunday Times yesterday that 1 in 5 Britons now want to start a health and well-being business. Not sure why, but yeah, I know I thought that was crazy as well. Yeah, Sunday Times, I totally believe it. So with that in mind, people like your personal trainers and Pilates instructors and people who aren't medical but are going to be seeing these people because everyone wants to get back to health. I think this is all really important, because everybody, all of us, no matter whether we're physios or whether we're kind of health professionals and well-being professionals, we should be monitoring these patients quite closely and making sure that we're giving them the right stuff if they're coming to us for exercise and as well as medicine. So that being said, so what kind of signs and symptoms should a therapist look out for to determine if there is a breathing mechanics problem, and if that's been altered or if there's been any issues?
Yeah, so I guess to start with, thinking about COVID itself, we know that some of the symptoms of the virus is shortness of breath, and fatigue and chest tightness and things like that. And one of the symptoms that can persist for patients longer term, so there I'm talking about 6 to 12 weeks after the initial symptoms, is shortness of breath. And what we're finding, or what I'm finding as a respiratory physio, is that a lot of these patients are presenting with a disruption to their breathing mechanics. So that means the way that they are breathing and the muscles that are being used and the movement of the rib cage. Now, I guess first of all, for patients and for health professionals to be aware of, if you've got a patient that has come to you and they are still complaining of shortness of breath, doing simple activities where they didn't have shortness of breath before, then you need to be questioning why they're getting that if they've had COVID. So is it because they are just deconditioned and they literally haven't done anything for the last 3 months or however long it's been? Or are they getting associated symptoms with that, such as dizziness or heart palpitations or things like that? If a patient is saying that they're getting dizziness and heart palpitations, then that's something that needs to be looked at closer, or in more depth. So if this patient hasn't had a medical review before, either firstly via their GP, then they certainly should be having a review from a respiratory and or a cardiologist. And again, that would be something, if they haven't seen their GP about this already, I would say go to your GP, and then the GP can refer on to respiratory or cardiac consultants. If they have seen a respiratory and cardiac consultant and they've been cleared, and the heart is healthy and there's no abnormalities, same with the lungs, then it might be that we are thinking that the patient has a mechanical change to the way that they're breathing, and that's where somebody like myself would become involved in their care, in terms of diagnosing that or assessing them for that, and then treating them. And signs and symptoms for a breathing pattern problem are numerous, and I could bore you to death. But I guess in short, or in simplistic terms, when somebody is resting, so imagine we've got a patient lying on our plinth in our clinic room, or they're lying on their bed at home and we're examining them virtually, and they're resting, they're not moving a muscle, the breathing should be very relaxed. So there should be no apical movement. There should be no movement occurring at the top part of the chest. All the breaths should be occurring through the nose. So there shouldn't be any random gasps or any breaths occurring through the mouth. You do want to just check that the patient hasn't got any nasal disease or re-blocked nose, because obviously if they have, then they won't be able to breathe through their nose. But essentially it should be quiet, relaxed nasal breathing, no apical movement. All of the movement should be happening at the lower part of the chest, and the respiratory rate, so the amount of breaths that are happening per minute, should be between 10 to 14. And the rhythm, so the speed and the depth of the breath of each breath should be the same. If you've got somebody who is taking gasps through their mouth, there's lots of apical movement, and there's those random big fluctuations in tidal volume, so big gasps, then that is a sign that there might be a disruption to their breathing pattern.
Interesting. And once you've then established that that's an issue, so people have been cleared for heart and lung issues, and you're feeling that there's an issue with the mechanics of breathing, what are some steps to take to restore the mechanics of breathing?
Yeah, so I guess to add into what we were just saying before in terms of signs and symptoms, something that patients will describe are, or things that patients will describe are an inability to get a satisfying breath, an inability to kind of fill their lungs. They might notice that they're having to yawn or force a yawn to get a satisfying breath, that they're doing lots of gasps, that they're getting short of breath going up the stairs where they didn't before, things like that. Now that will kind of contribute with your assessment of somebody lying in supine, will point towards whether you think somebody has got a mechanical disruption to the way that they're breathing, and from there it's very much about, or what I do is I try and generate diaphragmatic movement with a patient. Now there's a number of different ways that you can do that, and I certainly thought, oh my goodness, how am I going to do this virtually? Like when we were all locked down last March, probably the same as you guys with your MSK patients, I thought, without getting my hands on somebody, how am I going to facilitate this? But actually, it's nowhere near as bad as I thought it was going to be, and actually really effective. And I think as a physio, it's made me a lot better at maybe explaining things and not relying on my hands.
Side of things.
Yeah, and not relying on my hands quite so much, which is actually really nice. But yeah, it's basically about trying to relax and turn off the accessory muscles in the top part of the chest and really get the lower rib cage and the diaphragm engaged. Now, that can be really difficult for some patients depending on the severity of their breathing pattern. And so there's several different strategies that I might use in that situation. But for some patients initially, they're literally only able to do 1 or 2 breaths using the lower part of their chest before then their body will kick in, use the apical muscles and force a big tidal volume breath to kind of play catch up, if you like. So it can be quite slow progress at the beginning, but it very much depends on the patient and how severe their symptoms are.
What are some of the cues you use in general? Like, if just run of the mill, what would be the first one you generally go to with people in regards to cueing and coaching?
So I think a big one for a lot of people is that patients think, and I totally understand why they might think this, people think that they need to be taking big deep breaths because some people associate breathlessness with low oxygen. Now, it isn't always low oxygen. Yes, we might get breathless in an acute situation if we've got a oxygen diffusion problem, and in it for whatever reason. There's numerous different reasons, but breathlessness doesn't mean that we have a low oxygen levels. If we're exercising and we're going out on a run, we get out of breath, and we're meant to be getting out of breath because we're working harder, we're working our muscles harder, and we need to get more oxygen round to those muscles. But breathlessness can also occur in a breathing pattern problem when those mechanics are impaired, because what happens when we use the top part of our chest is that we don't create adequate volumes, or we don't create an adequate negative pressure within our chest cavity for our lungs to fill adequately with air, and therefore somebody might have to breathe quicker, or there can be all kinds of disruptions to that breathing pattern, but it will present itself as shortness of breath. So the first thing that I say to patients is, you don't have to be either breathing as quickly as you are or breathing as deeply as you are. And they think, oh, but I'm short of breath, I need to breathe quickly, or I've got to take all these massive gasps. And actually, when somebody is doing that and they have a confirmed breathing pattern problem, doing that actually drives the problem. It's like adding fuel to the fire. So I think once you explain all of that, and I do my kind of breathing pattern mechanics chat and explain it in layman's terms, that kind of makes sense to them. And as soon as you can reduce the amount that somebody is breathing, things tend to fall into place.
Helen,
so if you're
just quickly.
Oh yeah, go on.
Go. I mean, I was just about to say, like, you're obviously Pilates. A lot of Pilates is about breathing.
Yeah.
What are some of the simple cues that you guys use in Pilates to help people with their breathing?
So sometimes, well, quite a lot of the time, we actually just don't talk about it, because most of the time, if you talk about it, then it brings people's attention to it, and so they start thinking about it, and they suddenly forget to breathe, or as Emily said, breathe quicker, breathe faster, that sort of thing. And also, it's a bit like, so I have quite a few pet peeves. If anyone's ever listened, you'll kind of probably have known that already. But this phrase in Pilates that exists, that says, inhale to prepare, exhale, and then whatever the rest of the phrase is. And actually, how many times will you sit there and go, I've got to inhale to prepare, exhale to take a step? I mean, you just don't. So actually, one of the best things that you can get people to do is not really think about it, because breathing is unconscious and we don't have to think about it all the time. And if they're holding their breath, if they're trying to force that air, that sort of thing, then I'll draw their attention to it, because there's your breathing dysfunction. But actually for most people, particularly if you're starting them in supine, which a lot of Pilates schools kind of look at starting in supine and doing a bit of, there's kind of categories which you generally follow through to get people up into standing and walking out. It generally calms them down anyway, because the movement is a bit slower. It's a bit more conscious thought in regards to where you are in space, what's going on. This is why that people say sort of Pilates and yoga is a bit more mindful, because it's not just how much can you push out. It's more a case of, what's my positioning? Where am I? So you're becoming a bit more in tune with your body, which naturally calms you down and makes you breathe a bit better anyway. So I think in terms of Pilates, for me, people who have pain, people who have respiratory problems, people who have a breathing dysfunction anyway, more often than not, don't draw their attention to it, but give them something where they can do, which is a relative rest, i.e. something supine, where they can have support and they can have an easy exercise to get them moving. And you'll quite often find that their breathing will just settle. The other thing that we've got in the studios is things like OOVs, which is a bit of a funny piece of kit, sort of shaped with curves of the spine. And actually, if you lie someone on that prone supine side lying, it's very supportive, but it's also very unsupportive. If you're very kind of uptight and holding yourself together, it will just throw you off, because there's no flat surface like a foam roller. A foam roller can only roll, whereas a OOV is a bit like a wobble cushion that can go in every different direction. And it actually really, really encourages that diaphragmatic breath if you're just trying to get them to balance. So quite often what I'll get them to do is quite simply, hold their hands up towards the ceiling and just be there, because the more they can settle and relax into that structure, then the more kind of they're breathing a bit more using their diaphragm. They let go through their accessory muscles, their kind of deep abdominals and stuff will start to fire naturally. They're not doing anything. They're literally lying on their back with their hands up in the air, but it's trying to kick them off. So your body's then naturally responding to something that you're giving it. So I think, for me, it tends to be just don't talk about it and see if you really do.
Short answer is don't.
I went off on a tangent there. Sorry about that. But what I was going to ask is, if you are a personal trainer or you're a Pilates person and you're starting to see these kind of people coming through your door where they said they've had COVID, they're trying to get back into exercise, they're not really short of breath or having difficulty breathing, they don't, they're not appearing to sort of gasp or have any of that sort of stuff, but they haven't really done any exercise since they had any symptoms. And we'll go with, yes, they were a bit fit before, because most people who are seeing a PT or a Pilates instructor were doing something before. So in that category of kind of fit, active, or at least enjoys kind of maintaining their health. And as they do exercise, they're starting to get breathless more easily. What would you recommend to the kind of PT Pilates person at that point?
So this is kind of, I guess, a bit more complicated than what we first thought, or certainly what I first thought, because like we were saying in the podcast before, I think as physios, and certainly myself, I thought that the way to get these patients back to what they were doing before is simply prescribing graded exercise, and slowly ramping up the amount that they're doing. And we were saying in the last podcast that actually, as time has gone on, we found that for a lot of patients, this isn't the way to go. Now, for a small proportion of patients, it might be. And in terms of how to assess which ones it's suitable for and which ones it isn't, we don't know. It's completely trial and error. There isn't this patient is going to be able to tolerate graded exercise and this patient isn't. It just depends what the patient, I guess, comes to you and says they've tried to do and how well they've tolerated it. Now, with the patients that I'm seeing, for example, some of them have coexisting breathlessness, some of them don't. If we maybe take out the ones that have breathlessness, because I imagine that you guys are probably seeing the ones that don't have quite so much breathlessness. It's probably that, as you say, they want to get back to whatever they were doing before, but fatigue might be a factor, or at least it could be a factor, and certainly if we are increasing the amount of exercise that they're doing, it might raise its ugly head. And the reason being is that there is a lot of kind of chatter in the physio world, and I think in the medical profession in general, that long COVID is mimicking symptoms consistent with chronic fatigue syndrome, or ME. And our colleagues with a specialist interest in ME have been really pivotal in certainly influencing my practice in how to manage these patients, because there was a talk that I tuned into a few weeks ago. I watched it on Catch Up, actually, so it was probably back in November. This was probably about 6 weeks ago, but they were talking about the different causes of fatigue in chronic fatigue syndrome, and the fact that there can be peripheral causes of fatigue that affect the way that the mitochondria function, but there can also be central causes of fatigue that can affect the autonomic nervous system. Now, I'm not going to delve into loads and loads of detail, because it's something that isn't necessarily my remit, but it's important for us to appreciate this. And in particular, for me, I'm interested in how the mitochondria potentially would be affected, because what this means is that it will affect a patient's aerobic capacity. So they would switch into their anaerobic capacity. They would switch into their anaerobic capacity earlier, so their VO2 max would be decreased, and that has a significant effect on how much somebody is going to be able to push themselves and how soon they are going to get short of breath and fatigue. Now, I guess in the bigger scheme of things, what does that mean for us as physios in terms of prescribing exercise? And it means that doing or prescribing a graded exercise probably isn't the way to go initially. So I've been advising, and again, this is kind of following advice from physios who work with patients with ME. They are advising patients to keep a symptom diary initially of everything that they're doing in a day. And I know, like I said before in the previous podcast, it seems a bit basic and a bit of a bore, but actually it's really important to understand how much a patient is able to do and how fatigued that is making them feel. Because actually, if they're going about their activities of daily living and actually they're scoring quite high in terms of fatigue, even just doing basic ADLs, then actually how much have we got to play with in terms of what we can prescribe as a PT, as an MSK physio, as a Pilates instructor, whatever we're doing. And again, it brings us back to that battery level that I was talking about before, where we all have a certain amount of battery per day, like on our iPhone. Although the iPhone battery is rubbish, doesn't it? I swear it decreases. So let's not use an iPhone as a general phone. You have a battery level that does deplete throughout the day, and we have to charge it every night, like when we sleep. It seems that having COVID affects that battery level, and it means that simple activities like making a cup of tea, showering, going up the stairs, things like that are draining that battery level quicker than it did before. And therefore that means that we might not be fully recharging our battery level overnight. We might not be feeling fully rested. There might be activities that are draining the battery level that didn't at all before, and therefore that leaves us with limited capacity for other stuff. And I think that is where a lot of people are going wrong, because a lot of people are thinking, oh, I feel a bit better, I've managed to put the washing on today, and I've managed to cook a meal, and you know what, tomorrow I'm going to go out on a jog, or tomorrow I'm going to do an Instagram workout. And actually they go for it, and then the following day or even the day after, they're crashing and burning, and they're thinking, oh my god, like, what's going on? And it's this delayed post exertional malaise or fatigue that is coming on with these COVID patients, that, you know, we're still learning about this, and we're still learning about how to not only educate patients about it, but how to treat them in the longer term. So I think that's really important to be aware of if you're prescribing exercise.
So if you are a PT or working more in that kind of wellness side as well as physios, is there any exercises that you would say avoid? So particularly when you're first seeing someone again, when they're first getting back into exercise, is there anything that they should particularly be avoiding?
I would imagine, I mean, any high intensity stuff, I would say steer away from. So if you've got somebody that's got a Peloton bike at home and they want to jump straight back on that, that kind of thing, I would say, oh no, because there is also this guidance around heart rate monitoring as well for some of these patients. So what I'm trying to avoid is any huge fluctuations in heart rate when somebody is exercising, because again, this can contribute to this post-exertional malaise, and their breathlessness. You know, if somebody's got a breathing pattern problem as well, and they're really pushing themselves, quite often these patients don't deal well in that situation. So I think anything that's high intensity is probably not going to be a great idea to start with. I would say low level Pilates, Helen, with all of your Pilates, I'm sure that kind of lower level exercises in that way would be fine, because, correct me if I'm wrong, unless there's something that is going to particularly boost or spike their heart rate, it will increase a bit, but it's not going to be fluctuating hugely. Would you agree?
Yeah, I mean, I think it depends on what kind of Pilates that you're doing and where you're going to it. If you're doing kind of the more reformer fitness, if you've kind of gone to those big reformer group classes, or you're going and you're there to, you know, count to 10 and lift weights, then they generally sit more into the HIIT category side of it, because they will be there to work you as hard as you can and get on a sweat and do that. And that's this is going to sound very snort. That's not your typical Pilates, she says in sort of quote brackets, but that's more this kind of new category of more reformer fitness. But I think that kind of traditional, contemporary, classical kind of Pilates is, yeah, very much like that, is that you feel like you work quite hard, but you don't really get breathless. Your heart rate doesn't really go up very much unless you're doing some of the really high-end exercises, which, let's face it, most people are not going to be doing in their first sessions back.
Yeah. So I think all of that, I would imagine, would be absolutely fine. But I think for each therapist or each exercise practitioner, it's going to have to be a certain amount of trial and error, as it is for all of us. You know, when I'm advising somebody how much exercise to do at the moment, and I'm doing majority of this virtually as well, I'm not seeing people face to face in a gym or anything to prescribe it. It's quite low level, and even for some patients who are I mean, they're young, they're fit, but they are doing isometric muscle contractions, kind of seated. They're doing, you know, really, really low level, walking in the house, that kind of thing. And these are previously young, fit and active people beforehand. So walking plans can be another one that they can do. can set somebody up with a walking plan at home, some gentle stretches, things like that. I mean, I'm talking on a basic level here, somebody that's really struggling with fatigue. But again, the physios for ME, specialist interest group, I think that's the right term. I apologize to those guys if I'm using the wrong kind of bracket or classification for them, but they've been really helpful, and their website is super helpful and informative as well.
Has there been any are you guiding people in regards to like RPE or anything along those lines for people that might not have a heart rate monitor or something similar?
I haven't been, actually, because all of mine really have had Apple Watches or
Most
that
do
kind
these
of
days,
thing.
don't they?
I know,
Yeah.
we seem to be in that kind of era, don't we? Or it has been people who have, when they had COVID, bought a little pulse oximeter that they put on their finger, and it says their oxygen levels and their heart rate. But you certainly could use that, an RPE scale or a Borg breathlessness scale. You definitely could. I guess the only thing to be aware of with something like that is, what I'm finding in this cohort of patients is that their heart rate is spiking more than their breathlessness. Not in all patients, but yeah, so that's just something to be aware of, because if you were kind of doing an exertional or a breathlessness scale, they might be scoring quite low, but actually their heart rate might be quite high. So yeah.
And again, and we touched on it a little bit before, and certainly touched on it in podcast one, the exercise or activity diary. So not just exercise, but activity as well. That could you just speak a little bit about that more 24 to 48 hour response? Because that's not always matching up for people, is it? In regards to how they feel while they're doing the activity 48 hours later, that might be when it's having its effect.
Yeah, totally. So I think a lot of people are thinking, like we were saying before, oh, well, I feel all right and I've done XYZ today, so I'm going to try a workout, going for it, feeling all right when they're doing it, or maybe feeling a little bit more breathless, but putting it down to deconditioning and having not done anything for a certain amount of weeks, which you would, and then all of a sudden 24 to 48 hours later completely crashing and ending up kind of in bed, and that is happening more and more. So it's something that people need to be aware of if they're seeing a patient that's coming back to them having had COVID, and the patient is saying, I want to get back to what I was doing before, I want to be lifting XYZ, or I want to be doing whatever. I would just, as a therapist or a practitioner, I would just tread carefully and make sure you've got a thorough history. So completely redo your subjective history with that patient, and ask some of the questions that we were talking about before, particularly relating to whether they've seen a GP or a respiratory or cardiac consultant, depending on what symptoms they're telling you that they've got.
I think that's actually a really key point for the kind of PTs or Pilates guys listening, because how often are you sitting there going, oh, I've got a patient that wants to see me every day, but it's okay, I'll do something different. And actually, if you've seen them when they've come back and then they happen to see you the next day and they're just tired, then you should think very carefully about whether actually they should continue with that session, or whether you need to kind of tone down and see them less frequently, particularly at the start.
Yeah, definitely. And I think one of the main, not problems, that's the wrong word, but I think one of the main kind of hurdles for a lot of these patients is that they want to crack on, they want to get better, they want to be proactive and help themselves, and they think that by being active and doing stuff, that is what is going to get them better. And actually, and normally, as physios, would be like, oh my god, yes, this is the perfect patient, they're motivated, they want to do stuff, we can work with this, this is great. But actually, to have to completely turn that on its head from our perspective, but also change the mindset of the patient and say to them, do you know what, actually in any other situation, yes, we would agree with you, and you should push yourself to a certain extent, but in this situation it's just not the way to go, and explaining and educating them why, and we're still learning why, but we can only go off what we've learned from other people who have had COVID and other professionals, and this is certainly what's coming out from all of that we've learned over the past year or whatever, that don't try and be a hero. It's not going to be a quick fix for a lot of these patients. For some of them it might be, but for a lot of them it's not going to be. And yeah, keeping a symptom diary. Reece, I don't know whether we actually did we answer that? Sorry, I've just looked at you and thought, oh, you're listening so intently, but did we actually answer the bit? Did I actually answer the bit about your symptom diary?
Well, yeah, I think you did. And
Okay.
I guess the point I just really wanted to highlight for therapists is that 48-hour response. I think that was
beg your pardon.
the big thing for me, especially out of the first podcast that we recorded, was that just because someone's feeling okay at the time that you've done exercise with them, make sure you're gauging what's happening over the next 48 hours. That was the important, the take-home message big time for me out of episode 1, certainly. I just wanted to re-highlight that second time around.
Yeah, good. As long as I didn't forget anything. Going off on a tangent.
In regards to that, Em, so that's one outcome measure or measure we can use, is the diary and how people are responding. Is there any others that you're using?
We use a few from a breathing pattern perspective, but again, I don't know. I mean, I can share them with you. It might be useful for people to look them up if they want to. So from a breathing pattern perspective, to analyze somebody's breathing pattern, actually, there's something called the Brompton BPAT, and that was established by some colleagues of mine at the Royal Brompton Hospital. And that is a really nice tool, which when I was talking to you earlier about having somebody lay down supine and looking at where the movement is happening and their respiratory rate and whether the breaths are erratic or rhythmical, that outcome measure analyzes each aspect of a breathing pattern disorder, and it's really self-explanatory, and I'm happy to share it with the relevant permissions and things, but it gives a score at the end of it, and if the score is equal to or over 4, then it potentially suggests that somebody's got a breathing pattern problem and would need input from a respiratory physio. So that's quite a nice kind of diagnostic tool. In terms of outcome measures, we also use the Nijmegen, which is an outcome measure to look for hyperventilation syndrome. We also use the dyspnea 12 or the D12, and that's for, again, breathing pattern problems. And we use the SEBQ, which is the self-evaluation of breathing questionnaire. There's various different fatigue questionnaires as well, and I think I'm right in saying that there's no one that has been kind of proven more effective, unsurprisingly, yet, because we're early days, but proven more effective for COVID. But again, the physios for ME have got a long list of different fatigue questionnaires that they use. And we're using the VAS quite a lot, like I said before, just in terms of when we're getting patients to record symptom diaries and things, we just say use a visual analog scale of how fatigued you feel. It's easy for a patient to understand, it's quick, it does the job.
Yep. So I mean, there's some really good resources there, and I can find some links and pop them in the show notes as well, and underneath, just if people want to find those ones to be using.
Yeah, cool.
And in regards to exercise, obviously, being an MSK clinician, I love to get people exercising. It's what I do most of the day. Is there any way of guiding where we should be starting these people, people who have had COVID and wanting to get back into exercise, apart from, someone comes in, sees me, is there any indicator of how hard we should be pushing them apart from that response in the 24 to 48 hours? Is there anything that's giving you an indication of where we should be starting them?
No, not really.
Simple.
I'm gonna be honest. I'm gonna be totally honest. No, not really. It's, you know, it's the same for me, although I'm probably dealing with patients at maybe a lower level. They are still patients that are young, previously fit, want to get back to stuff, but they're probably not at the stage where they want to come in to a gym environment, if that makes sense. And I'm literally just kind of seeing how patients respond, but I am being very, very cautious. So whereas I would usually say, okay, let's, I don't know, for example, let's get you walking on the treadmill and we'll start maybe doing some interval hill walks or some interval jogs or something like that. I would literally just be getting them walking on the treadmill slowly.
So, well, I guess well short of the mark of where you think
well
they
short of the
should
mark.
be. Dial
Yes.
it right back and start from there.
Yes, and during that initial session, introducing the symptom diary as well, because I definitely want to know how they're feeling that evening. I want to know how they're feeling the following day, and I want to know how they're feeling 48, 72 hours after. And they are, if you know, if they don't like it, then they're going to learn the hard way. And I don't mean to sound horrible, but we're doing it to try and help them. And actually, if they do feel fine, great, then we up it that little bit next time. But what we've got to work really hard at is finding a baseline, because we don't know what the baseline is. And I doubt the patient knows what their baseline is unless they come to you having already spoken to somebody, having already done a symptom diary and said, do you know what, I think my baseline is here, I think this is where I'm starting at. So establishing a baseline has to be the way to start, and then we build on that.
And that's not necessarily what we'd normally do by chuck you on a bike, how long does it take you before you fall off, and
exactly.
all of those sorts of things.
Exactly. So it's totally changing our mindset, isn't it? And I mean, you know, I'm certainly learning as I'm going along, and I think that in a way we need to look at that positively, because it's refreshing for all of us, isn't it? And I know it's in a horrible situation, and this virus is horrible, and it's affecting people in a really, really horrible way. But I think if we can learn together as we go on and ultimately help these patients, then that's a positive thing.
And I also think it's quite important for us to ask the questions. So make sure we ask people when they come back to see you, how have you done in the last 48, 72 hours? Has it stopped you doing the washing up? Have you been able to do the laundry? Have you been able to play with your kids? Whatever it might be that's normal for them. Because if you don't ask the questions, quite often patients won't tell you the answers.
Totally. And actually, I've just remembered there was a app that, in terms of this whole symptom diary thing, there is an app called Bearable. Yeah, Bearable. And the icon on the iPhone is like a little polar bear, white polar bear with a blue background. But that app, for a lot of our patients who, you know, don't want to do an Excel spreadsheet or write something down, they want to have something on their phone, that app is free. You just have to sign up with your email. But you know, download it as a therapist or an exercise practitioner as well, because it's quite useful to look at, that patients can record symptoms on there. So symptoms of everything, fatigue, mood, their sleep, everything like that. And it can also give like a trend, and so it could be something that you could look back on with them when they come and see you next time. Or they can just do it, you know, pen and paper, whatever, but that's quite a good app that I've come across.
What about, are you using much of the wearable sort of data? Like, I know my watch tracks my heart rate and stress levels and how recharged I am over the course of the day. Like, I don't know how accurate they are, but have you been using any of that from people's Apple Watches or Garmin's or whatever they're wearing?
Yeah, I have a little bit. And quite often people will come in and they will say, oh, well, you know, look, this is what's been happening to my heart rate here, there, and everywhere. This is what's been happening with my sleep. And yes, so I have been looking at that, and I think if people have got that, particularly from a heart rate perspective, and they've got a reliable watch, you know, not one that's, I'm not going to name any brands or anything, but you know, one that's maybe not very reliable, then interpret that with caution. But there are some out there that are relatively decent. I think it's not going to be, just remember, it's not going to be as good as having a medical piece of kit monitoring heart rate or oxygen levels or anything like that, but it does offer a little bit of extra information rather than not having one.
Yeah, absolutely.
Amazing.
Yeah. Now, just one thing where some really fantastic information here. The last thing from me is in regards to exercise, because I love exercise, the type of exercise you're starting people with, probably, comparing, say, cardio, like getting on the treadmill versus some
Strength.
resistance exercise, some strength related exercise. Are you favoring one over the other, or are you combining the two? Are you advising starting in a certain position for people or certain type for people?
I'm doing a little bit of both, just because that is what I would normally do. I wouldn't just do one or the other. And I'm starting with no resistance, so body weight in supine, that kind of thing. And in terms of cardio, I'm starting with walking or stairs, or again, it depends on their level. You might be able to start a little bit further on than that, Reece and Helen, depending on what you found from your assessment and their baseline. But yeah, for me, I'm doing a combo of the two. And I'm sometimes saying to patients, do one day where you're doing a bit of your walking, leave it 2 days, and then on the 4th day you do a bit of the exercises that I've given you, lay down, that are body weight.
Okay.
Again, trial and error.
Start gently and work up, I think, is the take home from that, isn't it?
Carefully. Yeah.
Absolutely. Beautiful. Well, again, lots of information in there. So we thank you. It's been, obviously we're all learning on the job somewhat in regards to COVID, and as not just as physios, but as a medical and fitness community as well. And hopefully I know it's certainly the 2 chats that we've just had have been super helpful for me. I've got quite a few takeaways from them. So I do thank you.
My pleasure. And I guess, on a final note, I certainly don't know everything, and as I say, I'm learning as I go along. So if there's people out there that are listening that have got any other kind of insightful information or know anything above and beyond to kind of help my practice and your guys' practice, then I'm keen to hear. I'm all ears.
Yeah, sharing's only going to benefit everyone in the long term, isn't it?
Yeah, exactly.
So how would someone get in touch with you, Emily?
They can get in touch with us via the website. So our website is www.airphysiotherapy.co.uk, and our email address is hello@airphysiotherapy.co.uk. And we are on Instagram under Air Physio. We're on Facebook, Air Physiotherapy, and Twitter @Air Physio London.
Perfect.
Fantastic. Well, thank you very much, Emily. I really do appreciate you giving up your time for us tonight. It's been super insightful, and I hope for any patients or therapist/fitness people out there listening that they've got a lot from this.
My pleasure. Thank you. Thanks for having me.
Thanks.
Excellent. No worries. We'll see you again soon.
All right. Bye.
Bye. That concludes episode 17 of the Complete Health Podcast. If you haven't already, please do go back and listen to episode 16, which was a COVID special edition packed full of information for people who themselves have had COVID. This includes further explanation of the symptom diary Emily spoke about in this episode.
As always, if you'd like to get in contact, please feel free to email in at either reece@complete-physio.co.uk or helen@complete-pilates.co.uk. We're also on Instagram with our handle being @CompleteHealthPodcast, which is all one word.
For another week, stay healthy and goodbye.